So, very warm welcome to all of you to this conceptual anesthesia talk on traumatic brain injury. So, this is a very common cause of admission to critically care units and the ICUs worldwide, especially the neuro ICUs. So, I'll be talking about this in detail. Initially, I'd like to introduce the topic. We'll talk about a bit of the pathogenesis, why is TBI important, what are the classifications, what do we mean by primary and secondary injury, and what are the latest guidelines. So, traumatic brain injury is there is an alteration in the brain function or other evidence of brain pathology caused by external force. So, it's a brain injury caused by a trauma. And the most common mechanisms of injury are motor vehicle accidents, falls, and blunt injury to the head. So, what is the pathogenesis of this injury? So, it's a complex process that results from primary and secondary injuries that lead to either a temporary or a permanent neurological deficit. So the primary deficit is related to the primary external impact on the brain. So there is a trauma to the brain and this causes the primary deficit. Whereas a secondary injury can happen from minutes to days from the primary impact, and it consists of a molecular, chemical and inflammatory cascade responsible for further cerebral damage. So primary deficit happens immediately and this is directly to the primary external impact, the injury actually, whereas secondary injury can happen from minutes to days. So there is a release of excitatory neurotransmitters such as glutamate and aspartate that lead to intracellular increased calcium, which activates a series of mechanisms like enzyme caspases, calpases, and free radicals, leads to degradation of cell either directly or indirectly through an apoptotic process. And this degradation of neuronal cells is associated with the inflammatory response that further damages neuronal cells and incites a breach in the blood-brain barrier, further cellular edema. So this entire process is upregulated and downregulated by very several mediators. So there is an injury to the brain and there are several neurotransmitters and mechanisms leading to increased intracellular calcium, leading to activation of enzymes which actually lead to cell death and then can lead to the damage of the blood-brain barrier. And after the second injury phase follows a recovery period. So there is a prolonged recovery period which consists of reorganization. There's the anatomical, molecular, and functional level reorganization. So, as we all know, hypertension, alkalemia, and hypocapnia, that is decrease in CO2 levels, this results in cerebral vasoconstriction and decreased cerebral blood flow. While hypotension, acidemia, and hypercapnia result in the vasodilation and increased cerebral blood flow. So, this we should all remember. This can even come as a multiple choice question. I'll repeat: hypertension, alkalemia, and hypocapnia leads to cerebral vasoconstriction, which leads to decreased cerebral blood flow, while hypotension, acidemia, and hypercapnia results in vasodilation and increased cerebral blood flow. Other thing we should keep in mind is the Monro-Kellie Doctrine, which states that the ICP is directly to the volume of intracranial content. So brain is taken to be as a fixed cavity, and the contents are brain parenchyma, blood, and cerebrospinal fluid. So the brain parenchyma constitutes 83%, cerebrospinal fluid 11%, and blood is 6% of the intracranial compartment, which is taken as a fixed compartment. So each of these elements relies on one another. So the idea is that brain is a fixed compartment and these three have to balance out the volume, and if volume of one increases, then the others are compressed. So when intracranial volume exceeds that of the normal constituents, a cascade of compensatory mechanisms take place. An increase in the intracranial volume can take place in a traumatized brain via mass effect. So initially there is a cytotoxic edema, which is the main culprit in traumatic brain injury. And then finally, when the blood-brain barrier is broken, it leads to vasogenic edema. So we should remember the Monro-Kellie Doctrine. An edematous brain tissue will initially cause an extrusion of CSF. So when the brain parenchyma becomes edematous, it increases the space that it takes and the CSF is pushed out to the spinal compartment. And eventually, when the CSF is compromised, then the blood is, especially of the venous origins, is also extruded away from the brain. So without proper intervention and sometimes even with maximal intervention, the compensatory mechanism fails and end in the pathologic brain compression. So how do we classify? Another thing is mild, moderate, and severe. This is based on the Glasgow Coma Scale, which we all know. Mild is GCS 14, 15, moderate is GCS 9 to 13, and severe is GCS less than 9. So this GCS, we should all be aware, there are three constituents: eye opening, best verbal response, and best motor response. Eye opening is from 1 to 4. There is nothing as 0. So minimum GCS is 3. In eye opening, verbal and motor, minimum is 1 and the minimum GCS is 3. The maximum is 4 plus 5 plus 6, that is 15. You can remember this by the mnemonic EVM. Eye opening, verbal response and motor response 4, 5 and 6. In eye opening, first is the patient has spontaneous. So the best response is GCS 15. That is why when you see there is a mild injury, the GCS is 14 to 15. So best response is always higher. So in eye opening, a spontaneous eye opening is score 4. Eye opening to speech is for score 3. Eye opening to pain is score 2. And no eye opening is score 1. Whereas best verbal response is 5. The patient is oriented to time, place, and person. That is 5. Confused, that is 4. Inappropriate words is 3. And when he does not say any words, there is incomprehensible sounds, it is 2. And no response is 1. Then motor, the maximum is 6. When the patient follows your commands, it is 6. He localizes to painful stimulus is 5. He withdraws from pain is 4. And there is flexion to pain, that is 3. And extension to pain is 2. So extension to pain is like decerebration. And no response to even pain is none. So minimum is 1, 1, 1 in all. Minimum is 3, maximum is 15. Okay, and remember by the mnemonic EVM. So like GCS, we have pediatric GCS. Again in pediatric GCS, we have E, V, M and again 4, 5 and 6. So minimum is 3, maximum is 15. Then I would like to introduce 4 score. So in 4 score, we have eye response, motor response, brainstem reflexes and respiration. And here the score ranges from 0 to 4. Okay, in all the 4. So minimum is 0 here and maximum is 16. You should remember eye response, motor response, brainstem reflexes, and respiration. Okay, brainstem reflexes, respiration. So full outline of unresponsiveness, that is, it was called 4 score, is a coma scale that can predict the outcome of patients with traumatic brain injury. And 4 things are taken: eye response, motor response, brainstem reflexes, and breathing pattern. And all have a score of 0 to 16. A lower score indicates a greater impairment, as in GCS. And the advantages over GCS is intubated patients, the 4 score can cause be used to rate all the components in the intubated patients, while GCS cannot. So if you see the respiration, there is regular breathing, chain strokes breathing, irregular breathing, breathes above the ventilator rate and breathes at the ventilator rate or apnea. So all kind of breathing can be taken into account. The 4 score may provide additional prognostic information for patients with low scores. And all the components of 4 score are given equal unlike the GCS. So GCS has EVM 4, 5 and 6. 4 score, everything is 4. Now the classification is penetrating versus closed injury. So penetrating is when something penetrates, like foreign object enters the brain like bullet, and damage occurs along the path of injury. The symptoms vary according to the part of the brain that is damaged. Whereas closed is, it results from blow to the head, and it is mainly of two types: primary and secondary. As I told you, primary injury occurs at the time of impact, and second injury is later. Secondary one is over the hours to days of the primary injury, and it can result occur on the both microscopic cellular level, can result from conditions like macroscopic level, like a mass effect of the subdural hematoma. And remember, secondary brain injury is a major determinant of the clinical outcome. So the whole idea is to treat the primary injury and to prevent the secondary injury. This is just an example. The secondary brain injury can be a brain edema, increased ICP, intracranial infection, and seizures. Now, a bit about all the types of injuries that can be there. So, concussion is often viewed as a mild traumatic brain injury without any gross structural damage secondary to a non-penetrating traumatic brain injury. So, there's a non-penetrating injury, there's a blunt injury, which leads to no gross structural damage, and there's a mild traumatic brain injury. That means GCS is around 14 to 15. They usually follow direct blows to the head with subsequent acceleration and deceleration forces taking place. And it typically leaves the individual with varying levels of transient altered mental status. So there is the alteration in the mental status, but it is transient. It is not for a prolonged duration of time. It ranges from slight confusion to an actual state of unconsciousness for few minutes. So there is a mild traumatic brain injury, and it is from a non-penetrating traumatic brain injury, and there is no structural damage. So that is what is concussion. Then comes epidural hematomas. These are, and both EDH and SDH, as we all know from our undergraduate days, they are both extraaxial hematomas. EDH usually results from direct blow to the temporal region, where there is disruption of the middle meningeal artery. And usually there is a skull fracture along with EDH. Since it's an arterial bleed, EDH can rapidly grow in size. So, causing an individual to present with essentially normal mentation, and then it follows to a deterioration down the cascade of herniation as the ICP is rising, and as I told you, the brain compartment is fixed. So, when there is a too much of bleed, the ICP rises. SDH has varying presentations based on the age of the patient and chronicity. So, SDH can be acute and chronic. EDH is from arterial bleed, it is usually acute only. SDH is in the setting of trauma that often takes place via acceleration deceleration of the surface of the brain against the undersurface, and this leads to shearing injury to the bridging veins. So cortical bridging veins are the cause of subdural hematomas. EDH is usually a middle meningeal artery along with a fracture. Acute SDH can be quite dangerous for the patient as it generally involves a much higher degree of underlying brain injury than does a EDH. In a subacute and chronic setting of SDH, the clinical presentation is not as rapid and progressive as the acute phase. So, chronic appearing SDH tends to be encountered in elderly populations. What happens in elderly populations? Usually, the brain shrinks, the brain size decreases, so there is space that bleeding has already occurred over the period of time, and the brain compression is still not that much. And these patients are usually suffering from maybe cardiac problems or some stroke previous, and they are on anticoagulants on antiplatelet agents, making them much more prone to SDH with even a small injury. The usual presentation of subacute and chronic SDH tends to be more insidious in nature. It grows over time. It is a chronic thing. The patient can present with hemiparesis, headaches, speech problems, confusion. So when you have these kind of symptoms in an elderly population, always get a non-contrast CT of the brain, which will tell you whether the patient has a chronic SDH or subacute SDH. Then contusions. They usually result from a coup and a counter coup injury. So what is a coup and a counter coup? Coup injuries occur at the site of the impact, while counter coup injuries typically occur at the place of the contralateral side of the impact. So at the site of impact is the coup injury, and to the opposite side is the contralateral side is the counter coup injuries. And another thing is SH is most often associated caused by trauma and takes place when small capillary tears and ultimately blood spill transit into the SAH, the subarachnoid space. This is not as severe as aneurysmal bleed from SAH. Another thing is diffuse axonal injury. Is the axonal shearing injury? There is significant rotational plus acceleration deceleration forces are required to be there if the patient has to suffer a diffuse axonal injury. And it is often picked up on T2 weighted images and gradient echo sequences. And they are subtle hemorrhagic foci present in the corpus callosum, internal capsule, brainstem, and the thalamus. That is a diffuse axonal injury. And it depends where the axonal shearing takes place. The patient can have varied clinical presentations. The patient can lead from a very simple presentation to a very dangerous presentation in diffuse axonal injury. There is a subset of patients who are altered conscious for few days, while others present with hemiparesis from internal capsule involvement. So the place of the injury, the actual place in the brain where this rotational shearing deceleration occurs, that tells you what are the signs and symptoms of the DI patient. And the other extreme is the patients who never regain consciousness due to loss of axonal integrity, because this involves the reticular activating system. So diffuse axonal injury can vary in the presentation. Now we come to the management. So the pre-hospital management is, again, it starts from the airway, breathing and circulation, disability and exposure and to the environment. So ABCD approach, as on all traumatic patients, we follow that. And especially in the first hour in traumatic brain injury, we have to be very clear. We have to initially secure the airway if the GCS is low. I'll be telling you the indications of intubation. We should prevent any secondary brain injury. So why can a secondary brain, it can occur from hypoxemia. So we have to maintain oxygen saturation of more than 90%. Hypotension. So we have to maintain the BP of more than 90 millimeters of mercury. The patients usually have trauma, so we have to take cervical spine precautions. I'll be telling you how, when, and where we require a head CT, and if the patient is going for herniation, we have to act immediately. So neurological assessment involves the GCS, the pupillary response, including the sight, the size of pupil, and the light reflex and accommodation reflex, and the symmetry of motor function in the extremities. So all the four limbs should be checked for movement. And remember, this is a patient of trauma, so they can have another other injuries. So we should do a E-fast in them, that is, an extended fast, to look for the other sites of bleeding, including the pleural spaces and the four spaces in the abdomen in the fast. And if the patient is having hemorrhagic shock, this takes precedence over the neurosurgical procedures that the patient may require. So first, the idea is to stabilize the patient and then go for neurosurgical procedures. If the patient has no injury, only brain injury, the raising of the head in a brain injured patient individually generally has rapid effects. So ICP is reduced by displacement of CSF from the internal compartment as well as promotion of venous blood flow. So when you elevate the head, as I told you, the brain is a fixed compartment, but remember, you have to take into account whether the patient has other organ injuries or not, and if it is hypotensive, we should not do head elevation. Adequate oxygenation, maintaining a PO2 of more than 60, a saturation of more than 90% is a priority. As I told you, endotracheal intubation we have to do in patients who have a GCS of less than 9, that is less than equal to 8. They cannot protect their airway and maintain the airway reflexes. You realize that you need to ventilate a patient to maintain the oxygenation levels. That is another indication for intubation in such patients. And clinical signs of cerebral herniation. You have to strictly monitor these patients. All patients of traumatic brain injury should be monitored. And this includes the heart rate, the blood pressure, the respiratory rate, capnography if they're intubated, and temperature. And we have to avoid hypoxia, hypotension, hypoventilation, hyperventilation. So when you think that the patient can have herniation, so this is showing a bleed which can lead to herniation and various processes. So what are the signs of herniation that we have to keep in mind? So it can be pupillary asymmetry. So pupil should be measured after the patient has been resuscitated and stabilized. And asymmetry is defined as more than 1 millimeter difference in the diameter. And a fixed pupil is defined as less than 1 millimeter response to the bright light. So the pupil usually constricts to bright light when there is no response or less than 1 millimeter response. That means the pupil is a fixed pupil. So pupillary asymmetry, unilateral, bilateral, fixed and dilated pupils, decorticate or decerebrate, posturing, respiratory depression, and the Cushing's triad. So remember, for again a MCQ type, Cushing's triad is hypertension, bradycardia, and irregular respiration. So when the patient has any of these symptoms, that means that the patient is undergoing brain herniation, and immediate life-saving measures must be instituted in these patients, or otherwise the patient may collapse immediately. So as I told you, all the patients of we have to maintain whether they require airway is the first endotracheal intubation. We can elevate the head of the bed. We have to maintain a blood pressure and maintain head in a neutral position to have good venous flow. Then if you see that the patient is going into herniation, you should immediately, the measures that you have, you can hyperventilate the patient or give a hyperosmolar therapy like hypertonic saline or mannitol. So we are using more and more hypertonic saline these days. And remember, these all, if the patient is having any herniation, immediate measures are short-term temporizing measures. They are not a long-term measure. They are a short-term temporary measure. The long-term measure is a definitive one, usually a neurosurgical treatment. So you should involve the neurosurgery team as soon as you see a patient with traumatic brain injury having any signs of herniation or findings on the CT scan or the GCS is low. If there are no signs of herniation or after you've done the immediate measures and signs of herniation, you do a neurosurgical intervention. So they may proceed with evacuation of intracranial hematomas, or they have a insert a ICP monitor and monitor the ICP along with the placement of a external ventricular drain EVD is placed. Then if ICP is raised, they may require to drain the CSF continuously and maintain a EVD pressure of 20 centimeters. We have to be sure that the patient is having analgesia and sedation and maintain a cerebral perfusion pressure, that is mean arterial pressure minus the ICP of around 60 millimeters to 70 millimeters of mercury. If the ICP is still raised, we may require osmotic therapy. Again, as I told you, the preferred is hypertonic saline. A continuous infusion, try to maintain the sodium around 150 to 155. And if it is refractory, we may go for a decompressive craniectomy. This is just an example of an external ventricular drain, a small catheter inserted through the skull. Usually the aim is to the lateral ventricle, and it is enclosed collecting device where we can drain the cerebrospinal fluid. So we have to avoid infection in these patients. Okay, so aim is to avoid infection is the inpatients as well as measure the CSF, and if required, we need a continuous drainage of CSF to maintain a ICP of less than 22 and a cerebral perfusion pressure of more than 60, around 60 to 70 millimeters of mercury. As a last step, if the patient is not able to manage such a patient, you might lead to a medically induced coma, which usually nowadays is either due to with a benzodiazepine infusion or infusion of a barbiturate. And ideally, this should only be under the continuous EEG monitoring. The idea is to decrease the metabolic rate, the cerebral metabolic rate of the metabolic demand of the brain. Prophylactic use is not recommended. Remember, only as a last resort you can do a medically induced coma, but remember to always have a continuous EEG monitor in these patients. It is, however, recommended for severe refractory intracranial hypertension after maximum medical and surgical ICP lowering therapies have been exhausted. So it is as a last resort, remember. It is not to be done as a prophylactic thing. Now, a bit about the imaging. NCCT is the preferred modality. The indications are GCS less than 15 or a GCS of 15 with risk factors. So what are the risk factors? A patient with vomiting, some neurological deficit, we look at the injury mechanism, and so almost in all the patients, they have risk factors or some amnesia. We do a NCT head, which is the preferred modality of choice in these patients of traumatic brain injury. So subdural hematoma is a homogeneous hyperdense. So when the blood is there, it is hyperdense. It is concave or crescent shaped mass. So concave is, I'll be showing you, and it crosses the suture lines. And EDH is a lentiform and does not cross the cranial suture lines. Usually it has a fracture, as I told you. So this is a EDH. So as you can see, this is a lentiform. This one is a lentiform. Okay. And it does not cross the suture line. Okay. And this crosses the suture line. This crosses the suture line. And this is a concave or a crescent shaped. This is a crescent shaped. Crescent shaped SDH crosses the suture line. As I told you, SDH can be acute or chronic. Acute ones are hyperdense. Okay, the blood initially is a hyperdense. Then there's a hemorrhagic cerebral contusion, which is salt and pepper appearance with a mixed density. An open scale fracture, you can find pneumocephalus, that is intracranial air. So these are types of hemorrhagic contusion. You can see blood spots and some injury to the brain. And then there can be air. So this is how the air looks like. This is a depressed fracture. And this is how the pneumoencephalus air looks like, a black spot. The two CT guided scores that we should take into account. So I discussed the GCS score and the 4 score. Then there are two CT scores, that is Marshall score and Rotterdam score. So Marshall classification of TBI is a CT scan derived metric used only with few features. So Rotterdam is the most recent one. You should know that, and you should know that Marshall is also done for TBI. So it places the patient into one of the 6 categories depending on the severity of the NCCT brain. And higher categories have worse prognosis. The primary two features that it takes into account is degree of swelling. Degree of swelling is due to the midline shift of the brain and compression of the basal cisterns, and presence and size of contusions hemorrhage referred to as high or mixed density lesions. The Rotterdam is the most recent ones. So it includes the basal cistern like the Marshall system, degree of midline shift. Then it includes contusion but restricts to the mass lesions to epidural hematomas, and it has intraventricular and subarachnoid blood. So that is to be added. Again, this is a scoring system. If the basal systems are normal, the score is 0. If it is compressed, the score is 1. If it is absent, the score is 2. So if you cannot see them, if you can't visualize them, then the score is 2. Then midline shift, the more the shift, the more the score. Then it takes into account only the epidural mass lesion and IVH or subarachnoid hemorrhage. So ideally for us, we should remember the scoring system's name at least. Rotterdam, Marshall scoring systems. Fine. As compared to TBI. We should, as a critical care specialist or anesthesiologist, focus more on GCS and the 4 score and the initial management of the patient. I have talked about concussion, EDH, how they present, just to make you aware about what are the varied presentations of the patient of TBI. So surgical intervention is generally warranted when there is significant mass effect from either an EDH or a SDH or a contusion with significant volume of blood. So anything that can compress the brain, that can have a significant mass effect, we have to think about a surgical intervention. And the mainstay treatment for EDH is a craniotomy. So it does not cross the suture lines. We on the desired lesions, we do a craniotomy, evacuate the hematoma, cauterize the bleeding vessel, which is often the middle meningeal artery. Okay. What is for SDH? There is a much more significant underlying brain injury. So as I told you, it involves a larger area, crosses the suture lines, and not only the extraaxial blood causes mass effect, but the underlying cerebral edema is also leading to clinical deterioration. In case of acute SDH and there is severe brain injury, the decompressive craniectomy can be performed. Sometimes we can also do a standalone evacuation of SDH without temporary removal of the bone flap if we initial surgery is done. So again, neurosurgical intervention, what is to be done is not the prerogative of the intensivist. But he should be sure to have a neurosurgical opinion, especially if the CT scan shows a more than 5 millimeter midline shift or acute SDH of more than 10 millimeter thickness. In case of EDH, the volume is important, midline shift is important, and the GCS of less than 8 is important. And in others, if the patient is having comatose condition, you should think about a neurosurgical intervention, especially in cerebral contusions because the volume is high. Sometimes it leads to the midline shift. Now, for us, the most important thing when the patient comes back from the operation theater or maybe he's not operated, we have to prevent the secondary injury. The primary injury has already happened. The idea is to prevent the secondary injury. So we have to maintain a good blood pressure, prevent hypotension, prevent hypoxia, prevent hypercapnia or hypocapnia, and maintain a ICP and a cerebral perfusion pressure. So these are the things that are total prerogative of the intensivist or a neurosurgical person, neurosurgical anesthetist. So the blood pressure in age of 50 to 69, it is more than 100. And in patients who are less than 50 and more than 70, we have to maintain a systolic blood pressure of more than 110, that is more than 110 millimeters of mercury. Avoid hypocapnia. We have to maintain an ICP of less than 22 and a cerebral perfusion pressure of 60 to 70, that is mean arterial pressure minus the ICP. Again, this just tells you what are things that are important for us. So when you have such a patient, you should think about these all things. Okay. For outcomes, they have no role in traumatic brain injury. Administration of tranexamic acid with 3 hours makes mortality, but it's not usually rolled. used routinely. Seizure management. Phenytoin nowadays sometimes people use levetiracetam used within the first 7 days to prevent early seizures in traumatic brain injury patients. So the idea in temperature management is to avoid hyperthermia and even to avoid hypothermia. And you can use hypotonic saline mannitol to reduce ICP, but there is no improvement in outcome or mortality because of these patients. Then nutritional therapies, these are patients who might require ICU stay for a prolonged stay. So again, enteral nutrition is preferable. The aim is to have enteral nutrition build up from 4 to 7 days. 7 days the maximum that we want to have a full caloric replacements. And the caloric requirements are in moderate to severely injured 25 to 30 kilocalories per kg and severe is 30 kilocalories per kg. Now, what is the role of decompressive craniectomy? Again, as I told you, it's mainly a neurosurgical person has to decide. The idea that decompressive craniectomy can lead to decreased ICP and minimize the days in the ICU, but it is only to be used in patients when it is desired. It is not recommended to improve outcome in patients with diffuse injury and with ICP values more than 20. Remember, a large FTP, frontotemporoparietal decompressive craniectomy, it's usually done for the SDH, is recommended over a small one. So idea is to do a large one because it has been shown to reduce mortality and improve neurological outcomes in patients with severe. So they have compared a small and a large one. Although the indications are to be decided by the neurosurgical person. Hypothermia is not recommended as I told you to improve outcomes. Okay. CSF drainage and EVD system zeroed at the midbrain with continuous range of CSF may be considered to lower ICP. So as I told you, EVD, which is a closed system to avoid any spread of infection, is used to measure the ICP and to maintain it less than 22 millimeters of mercury. And you have to zero the EVD at the midbrain, and there is a continuous drainage is preferred over an intermittent use. Use of CSF drainage to lower ICP in patients with the initial GCS of less than 6 during the first 12 hours may be considered. Again, it is just may be considered. Prophylactic hyperventilation is not recommended. Only in patients who are being planned for neurosurgical intervention and are having immediate signs and symptoms of brainstem herniation, you can think about prophylactic hyperventilation or short duration of time. It's a temporizing measure for reduction of the elevated intracranial pressure. Hyperventilation should be avoided during the first 24 hours. Okay. And if you are using, you have to measure the brain oxygen levels or the jugular oxygen levels, ideally to monitor the oxygen delivery to the brain. So hyperventilation is not a routine process. It is actually very dangerous to the patient. It is only to be used in patients who are being planned for neurosurgical interventions when they have a signs and symptoms of herniation. So what does hyperventilation do? It lowers the ICP by reducing the intra-arterial PaCO2. So if you decrease the PaCO2, hypocapnia can lead to vasoconstriction. So vasoconstriction decreases cerebral blood flow, decreases ICP. But the side effect is again there is a reduction of the cerebral blood flow and prophylactic is non-recommended. So in patients and in areas of preserved autoregulation, as I told you, brain has an autoregulation and there are areas that preserved autoregulation is there. There will be focal is of ischemia. So you can cause more damage. So again, only to be used as a brief temporizing measure. Now, as I told you about medical coma, we can use administration of barbiturates or benzodiazepine to introduce a medical coma, but it is not recommended. It is just at a last resort, and we should always measure the EEG. So, EEG monitoring has to be done for continuous burst suppression when you administer medical coma as a last resort when you cannot decrease the ICP by any other measure. Now, early tracheostomy is recommended to reduce mechanical ventilation days when the overall benefit is thought to outweigh the complications. But remember, there is no evidence that early tracheostomy reduces the mortality or the rate of nosocomial pneumonia. So early tracheostomy is done in many places. The idea is to reduce the mechanical ventilation days, but it does not reduce the mortality. Low molecular weight heparin or low dose unfractionated heparin may be used in combination with mechanical prophylaxis. However, remember that these are the patients with traumatic brain injury and there is an increased risk of expansion of the hemorrhage. So they have to be used very carefully. In addition to compression stockings, that is a mechanical prophylaxis, pharmacological prophylaxis may be considered as soon as the brain injury is stable. And when you feel that the benefit of giving a DVT prophylaxis, preventing a pulmonary embolism, because these patients usually are bedridden for a prolonged duration of time, when you feel that the benefits they outweigh the risk of increased intracranial hemorrhage as the patient is stable, you can start with low molecular weight heparin or a low dose unfractionated heparin. Then, as I told you, prophylactic use of phenytoin or valproate is not recommended for late post-traumatic seizures, but definitely it decreases the incidence of early post-traumatic seizures, that is within 7 days of injury. Now, ICP monitoring, management of severe traumatic brain injury patients using information from ICP monitoring is recommended. So, ICP monitoring is important, we should know, but it should be a closed system to prevent any infection that can be introduced. It is indicated in patients with severe traumatic brain injury with a normal CT scan if more than two of the following features are noted at admission. If the patient has more than 40 years age or is having hypotension or unilateral bilateral motor posturing. So this is according to the Brain Trauma Foundation guidelines. If you have a patient with these indications, you should think about intracranial pressure monitoring. These are various type of monitors. So idea again is the brain is a closed compartment. So when brain is a closed compartment, the pressure transduced from one area to another is a similar kind. But in patients who we want to drain the CSF, ideally the best thing is when EVD into a lateral ventricle connected with a CSF drainage closed system. Now there's a tire therapy for ICP control. So when there is a increased intracranial hypertension or there is ICP is raised, cerebral perfusion pressure is decreased, you feel that the patient may go into herniation, we use a standard measure. What are the standard measures? Maintaining a neutral position of the head, okay, elevation of the head end because it leads to decreased flow, increased blood flow venous and increased flow of CSF, maintaining high normothermia, avoiding hypotension, maintaining hypoxemia. So this is the first standard measure. So if they do not work and you're measuring the ICP, another thing is we can decrease. So as I told you, in patients who are going for herniation, you can think about a small CSF drainage, a temporizing hyperventilation, or a osmolar therapy like hyperosmolar therapy like mannitol. Second is hypertonic saline, or you may think about introducing medical coma. Always try to do that with a continuous burst separation EEG monitoring. In both of these subset of patients, you can go for a CT scan and you may need to have decompression of these patients. The last result is pentobarbital or phenobarbital or hypothermia, which is usually not to be done in these patients. This I already talked about. To summarize, management of TBI is based on the avoidance of secondary. So, as an intensivist, as a person managing the patients, you have to avoid secondary injury. You have to maintain cerebral perfusion pressure and optimize the cerebral oxygenation. So, if you remember these first line of summary, that is all you have to do as an intensivist. All your things that you do are related to these things. You have to do a multimodality monitoring of the injured brain because you have to individualize and optimize the patient management. So all the monitoring that is possible, including the IC monitoring, should be done in these patients, and we should use evidence-based guidelines and management protocols. So slightly off topic and not a basic topic, but if you have patients of neurosurgery in your critically ill subset, it is one of the most important parts, and trauma is increasing, motor accidents, falls, and the patients on anticoagulants is increasing day by day. So they may present with a chronic SDH, acute or chronic SDH. So you have to take these into account. Any questions? You can unmute yourself and ask for questions. So if there are no questions, we'll call it a day. Thank you.